Hi everyone, welcome to the Cambridge University Land Society webinar this morning. We are looking at the value of healthy placemaking. We've got a really exciting panel this morning. We've got experts with a huge range of experience in the healthy placemaking sector, which I think is going to bring a really unique perspective to this topic. I think it's an incredibly important topic at the moment, very topical. And I think we're really starting to, as an industry, understand the interconnection between health, placemaking, planning, and sustainability. So the ESG Forum at the Land Society is really happy to bring this group to you today. The running order of the morning is that we're going to have quick fire presentations from each of our speakers, lasting around 5 minutes. And then at the end of that, we're going to have an opportunity for a bit more of a discussion, which is an opportunity to bring together the expertise of our different speakers. Finally, at the end of the presentation, we are going to have an opportunity for Q&A from the audience. So as we're watching our speakers, please bear in mind that there's going to be an opportunity for that. So please, think of your questions. I'm Joanna Wilson. I am Sustainability Lead at Fletcher Priest Architects. As part of that role, I oversee across our different practice sectors, so from urban design, architecture and interiors, and also research. So I'm really happy to be chairing this discussion today. So our first speaker is Andrew Baroni, who's Associate Director of Healthcare and Planning at Savills. So I'm going to just share his slides very quickly, just to keep everything simple. Just give me one option. But Andrew, if you could introduce in the meantime.
Yeah, morning all. Dr. Andrew Baroni, I run the Health and Social Impact Assessment Unit at Savills, where I've been building health into planning for the best part of 25 years now. I think in running order-wise, putting me up front was possibly a mistake because I'm known to talk the back legs off a donkey. So I've got a 5-minute timer as soon as my presentation starts, and I will try and stick as close to that as I can. We've got some interesting speakers today, so I'm going to do the introduction to most of those aspects, and then there's more depth afterwards. So just waiting for the screen.
Yeah, sorry, Albie, I think I don't have sharing's not turned on. Could you just make sure that that's available to me?
Sorry, you can try now.
There we go.
Perfect.
Yeah, it wouldn't be a webinar without something.
There's always something. Just shows it's not pre-recorded.
Yeah.
There,
Right.
can you?
Yeah, so as I said, if you could do the next slide for me, please. I'm doing kind of the introduction to the piece. Next slide, Joanna.
Yeah.
Good stuff, which is very much the what, the why, and the how. It is light touch. Normally, this would be a 2-hour presentation on itself. Next slide, please. So on the what side of it, I've worked across just about every project you can think of, but it's next slide, please. It's the residential projects that keep me awake at night. They're the ones that terrify me the most, and they're the ones that you will have the most likelihood of working on, largely because what we build in will endure. The legacy of that will be there forever, and good or bad, you'll continue to influence health forever. Well after you've retired, well after your grandchildren are retired, that influence is still there. And it's the missed opportunities, not just for the physical infrastructure, but how you may have modified behaviors or removed barriers that will uptake that benefit. That's really hits home. Next slide, please. So in terms of why we do it, this is a snapshot of what just about every local authority is facing in the country. It doesn't matter how affluent it is, how big or how small, these are the same sort of challenges we're all looking at. And the ageing population is the big one at the moment. There's more of us than ever before, and we're aging. And with that, life expectancy is still creeping up slightly, but healthy life expectancy has not only plateaued, but in many places it's starting to reduce. So that means for a large proportion of us, we will see a lot more people living longer in poorer health, very much with an increase in long-term living conditions. So the inequality of that is also widening. We're seeing life expectancy differences within small communities in a very close proximity between 17 and 18 years. Special educational needs and disability is also something that we're starting to see an increase in the prevalence of it. We're not too sure if that's just improved diagnostic to actually monitor these things or actually an increase, but there seems to be an increase in the rates. That's putting an increased pressure on children's services and adult social care, which for every local authority is one of the key challenges for them. On the health and social care front, all of that means that demand is increasing. And even if budgets remained where they are, inflation is undercutting that, so the supply is reducing. And we know staff are leaving. So a treatment-based approach is just it's not viable, sustainable. It's not something we can keep up with. The reason why staff are leaving, it's not what you would expect. It's not just salary inflation, where if you work in public sector or retail, the gap is less in retail. It's also living conditions or being able to provide the level of care that they want to provide, mainly because of the quality of the infrastructure around them. Budget cuts are looming, and individual means, resources. People are getting on the housing ladder later in life. 42 is about the current age of a first-time buyer, which means they're less likely to have paid it off by the time they retire, which means they're more likely to fall into adult social care later and have less resource to pass on or support their children into getting on the housing ladder themselves. So all of these things are what local authorities are facing. And GPs, what you see there on the right is the number of GPs that have closed or consolidated every year since 2013. It's not small, and a lot of them are closing because they're just not viable. The buildings themselves aren't geared to new ways of working. The rates for pharmacies is even faster. Next slide, please. Now, this is a summary of all local authority budgets, and what you'll see is in 2013, half was geared to reactively addressing children's social care and adult social care. By 2023, 2024, you can see it's moved from half to nearly 2/3. Now, that's not demand, that's just the budget that we have to address the demand. The demand is more. So we're not addressing what is required. What's interesting is we're also pinching the rest of the council budgets. Environmental services, housing services, cultural related services, they're all being pinched. And that's across every local authority. And when you think that dementia prevalence, because of the aging population, dementia prevalence is set to double by 2035, it's just not viable. We can't continue the way we are. So healthy placemaking is really the only solution. Next slide, please. This one just demonstrates why the aging population is a challenge, because with age, the frequency, the complexity and cost of health and social care all increase. And acute beds, 25% of them are taken up by someone with dementia. Of those that enter from their own homes, 60% typically, only 36 ever return home. And it's because while they may be fit to go home, their homes aren't fit for them, or the places and spaces around it, the social support networks that they need aren't there. Next slide. It's the same for children's services. The demand is high, and the service provision, we're all actually competing for it across local authorities, to the point that it's now between £60,000 and £250,000 per child per year for external placement. It can be as much as £1 million. And local authorities, again, it's not something they can sustain. Next slide, please. So the why for placemaking is actually, why not? You know, the places we shape always shape us in return, then we know we can prevent more disease than the NHS can ever treat. So anything that would actually prevent, reduce or delay the need for clinical intervention and social care is essential. And it's not just about building things, it's about the behaviour aspects too, removing barriers to people using it. Next slide, please. So again, on the why, the influence we can have is profound. Physical activity alone, you can reduce senile dementia prevalence by 40%. And when you know it's going to double by 2035, that's the only option. That's the only way we're going to get on top of it. Likewise, cardiovascular disease, type 2 diabetes, hypertension, depression, mental health, stress, anxiety, these are all things that can be improved with physical activity, connections with blue-green environments. In fact, it's hard to find a disease state that can't be prevented or improved or treated through a more health conscientious environment or the social networks that you can foster through the design of places and spaces. Next slide, please. So on the how, there's broad design features, and I could talk for hours on each of these points, but do prioritize anything that your project can do to facilitate healthy, independent living for longer. A lot of that is based around physical activity, extensive green space, strategic trim trails, anywhere you can get people as either a mode of transport, recreation, or social gathering where they are active, physically stimulated, mentally stimulated, socially stimulated. Age and dementia-friendly design. These are things that we need to be considering within all of our projects now. And in simple terms, it's a loss of computing power. But the brain is amazing and it makes the most of what it has left. So you lose the finer detail, but you retain shapes, senses. So don't just have street names, have wayfinding, have art installations. So it's not just turn at Unicorn Street. You've got an installation of a unicorn such that he knows as soon as he's seen the unicorn, he lives there on the left. These features we know can actually help high-need individuals spend the rest of their lives in their own homes by up to 40%. So again, who loses there? It's what we all want. Neurodiversity-friendly design, again, these are features that are aimed to improve inclusivity, but they benefit everybody. Who doesn't value calming and sensory spaces? And in today's pace of life, they're becoming more and more valuable for mental health as well. So provided them, it's not just good for the individual, it's good for the person that's caring for that individual, where a family member who sees their child maybe starting to get overly stimulated by environmental stimulus, they can modify and manage emotional states far better if they know there's a place they can take them to calm that. And as that child learns where they are, the more of them that they're there, they can better manage their emotional state as they become adults. So you're preventing people going into children's services or adult social care entirely. Next slide, please. Then there's capital infrastructure, things that you can actually physically build in. For a lot of our developments, we'll be providing schools. Make them high-SEND capable and link them to play facilities. It's not just the facility itself, it's the network of amenities that go with it. Send libraries, provide space within the school so people can try, borrow, and in some cases never need to return items that would greatly enhance people's lives and address the fact that people, the inequality of it, where you're more likely to be deprived, more likely to have a child who has a SEND requirement in a deprived area. If they can borrow items like this, that that standing sitting wheelchair at the bottom, you don't know if it's any good for your child until after you've used it. You don't know how long it's going to be good for them. And it can be the cost of a family car. And same with all of those items. They're all prohibitively expensive in some cases. These are all features that you can easily build in. Now, I'm conscious I'm already creeping well up to my 5 minutes. So I'm going to leave these slide points here and hold up for questions later. So thank you.
Thank you so much, Andrew. As you said, that's such a good introduction to everything that we're about to discuss. Matthew, if you could come on and introduce yourself while I bring up your slides.
Hi, yes. So Matthew Harmsworth. I'm an associate planner at David Locke Associates. I am a co-lead of the Neurodiversity in Planning Network. It's worth referencing as well, given the topic being discussed today, that I've just recently been in another role at Arcadis a couple of months ago, where I was the global chair there for the Access and Neurodiversity Affinity Group across the company.
Right. I should have your slides there.
Thank you. Can we, yeah, that's fine. Actually, we'll start there. My topic today is mainly talking about neurodiversity. So neurodiversity is a term which, in its fullest sense, refers to the infinite variety of all human brains. Therefore, by definition, this is something which concerns everyone and is in everyone's interest. When you're creating places that for every mind, then this deeply embeds inclusivity. Often the term's used in the context of referring to specific diagnoses, such as those in the diagram on the right. But that's more about neurodivergence, a brain that's perceived to be different from what's considered typical, or considered different from neurotypical, if you will. Therefore, the statistic that you see at the bottom left there of 15 to 20% of the global population are believed to be neurodivergent, which is broadly the accepted estimate of the global prevalence from most bases. It's already quite large, but in many respects, this significantly underestimates the prevalence of the issue, given that we're talking about here beyond specific diagnoses. Next slide, please. For example, if you use me as a case study, while undiagnosed, my neurological and physiological experience of the world feels very much like it accords with that of a highly sensitive introvert, who are people who process every bit of stimulation deeply due to a biological difference in their nervous system. What's particularly interesting here is that many people don't think of this as a form of neurodivergence because they do not believe that high sensitivity to your environment should be considered a disability. But here's the point, that culturally we have a bias towards focusing on weaknesses of different brain types, or rather challenges, rather than focusing on the fact that when the needs are met, like you see for the example on the left there in the columns on the left, for my case, the result is the special strengths you see listed on the right for people who are highly sensitive introverts or similar forms of neurodivergence, which often, when those needs are addressed, present to an even greater level than what is often considered the norm. Next slide, please. So to use a couple of metaphors here, it's therefore not the case of addressing neurodiversity in terms of comparing it to flogging a mule, despite it often being treated that way in practice, where you try and get everyone to work, behave, and perform in the same way. Rather, it's like watering a seed. You give it the experience, tools, and environment that it needs that might be different to other seeds, so it can bloom and into something uniquely incredible in its own right. Next slide. So if we look at these statistics here, I'll let those sort of distill as I talk. If you have a look at those, these statistics and quotes go to demonstrate the point that whether at work, in design, in engagement methods, or whether you're looking at it economically by attributes or by quality of life, the difference in results is quite striking that you get when you consider neurodiversity. Imagine if you were to give one person a typewriter and another person a modern computer to do a desk job in these times. The person with the computer is far better equipped to do the job better and therefore will probably perform better. Likewise, if you give people the tools and the environment that allows their brain and physiology to perform its best, clearly you are much more likely to get better results. It becomes easy to see how approaches such as this, interestingly, to pick up on quite a topical point at the moment, will help to address the productivity crisis, which is perceived to be the case at the moment. Next slide. If we look at examples in policy, I love the Watford local plan as my go-to example of neurodiversity embraced within planning policy. So that has a policy within it that major new developments of 50 or more homes should have demonstrable regard to the principles of dementia-friendly design. So look at these principles for a moment. Energy efficiency to avoid overheating, internal layouts with good access to natural light, storage, and air circulation, an outdoor environment that's good for wayfinding and has good connectivity and flexibility, homes being designed to accommodate new technologies, buildings and layouts that create natural surveillance while still feeling homely. These are just good design principles for anybody. Like Andrew said, you design for the exception, in this case, dementia. It also results in you designing for everybody. Next slide. Neuro-inclusivity doesn't have to be expensive either. So last year, and I would thoroughly recommend this to anybody, I visited the headquarters of the RNIB, the Grimaldi building in London, which is designed for maximum accessibility that goes beyond the visual side of things. But one point here on that sort of visual experience kind of note and neurodiversity that I learned there while I was being toured around the building is that when you add 5% black to any color, for example, it instantly softens it and makes it easier on the eye, to put it somewhat crudely. So this applies whether you're painting walls or indeed to the 5% black I added to the background of this presentation to make it slightly easier on the eye than a plain white. Next slide. So think of this in terms of addressing the sensory experience principally when it comes to practice. How does this environment engage with people's senses of taste, smell, touch, etc.? For a site I worked on for several years ago, we did things like putting in an edible walkway, putting in amphitheatre landscaping, putting the bus stop next to the extra care facility, next to where the most vulnerable users will need it for who have the most difficulty accessing it. So you can see how sense of taste and smell is engaged with and is closely related to long-term memory. Amphitheatre landscaping engaging a sense of balance, that accessibility. Next slide, please. Another example, incidentally, this project won Planning Permission of the Year at the Planning Awards last year, and I led the multidisciplinary team to provide 16 homes for adults with autism and/or learning difficulties. And here there was a real focus on connection with nature, establishing a safety hierarchy and a fit out of the buildings, so that it addressed people's needs, the needs of those particularly vulnerable adults, while still, and it was sort of its own separately contained site, as it were. But as you can see from the layout plan on the right there, it's still integrated with the wider community. Next slide. From a policy perspective, it is there and taken into account. There are references within all of these different documents and pieces of guidance that are shown on the left here. But the issue perhaps is that it needs to carry greater weight within the planning balance. Within the case of the NPPF, for example, there is a reference to disability, and within the glossary, it's kind of buried in there that forms of disabilities can include dementia, autism, etc. And a lot of where it is with local policies, often it is guidance rather than a statutory requirement, as it were. So there's some way to go to make it carry the kind of weight in planning decisions that it should do, and indeed for the built environment, and equally for social value measures, often the employment and sustainability ones that carry the higher quantitative proxy metrics are given greater weight than those perhaps more directly related to health and inclusivity. Next slide, please. So in a nutshell, designing for neurodiversity and some key principles here. Think about it in terms of the sensory environment. How is this going to engage with people's senses? Build in flexibility, choice. Wayfinding is especially critical, and connect people with nature. That biophilic design, if you will, is critical for neuro-inclusivity. And as we heard from Andrew just a moment ago, looking at those cognitive decline and depression prevalence statistics, clearly the immediate and the long-term mandate is there for this. We just need to build upon it and allow it to carry greater weight within the planning balance. Thank you.
Thank you so much, Matthew. Next up, we'll have Michael. So Michael, if you could come on and start introducing yourself, and I'll bring up your slides.
Thank you. Good morning, everyone, and welcome to the webinar. So I'm Michael Chang. I'm the Associate Town Planner leading on the Healthy Planning work stream within the Town Planning team of NHS Property Services. What I'd like to do with my presentation is really to take you through a lot of the work that I've been focused on over the years to not just understanding how planning deals with the public health issues, but how to turn knowledge into action and obviously translate research into practice. So next slide, please. Thank you. So I'll provide a perspective on planning for health net gain in a way. Just going to say a lot of the issues that Andrew and Matthew raised, it's quite complex because we are dealing with people's lives and livelihoods and everyone else's as well. And so therefore, it's necessarily a complex issue. It's not just about doing one thing and then they'll lead to another, health outcome. It's actually quite a complex kind of a process as well. And many researchers, policymakers over the years, decades, have tried to map and visualize and identify what the complexity looks like. And these are useful in a way because that demonstrate that it's actually a complex issue, but it's also not useful because, well, where do you start? And all of my kind of research and work, both at work currently in my previous workplace and my research is looking at how do you take action so that you don't get bogged down with systems and structures, even though it's very, very important. There's a slight animation there, Joe, if you can click on. So I would like to focus very briefly on three things: on the system, the context, and capacity issues in my next three final slides. Next slide, please. Thank you, Joe. So one thing to say, a lot of the issues that we're dealing with could be built into the policy in the planmaking process and the documents that we produce in local authorities, because many decisions that we make on projects and places are actually based on and mostly based on these policies. Therefore, it's very important that we understand what these policies say. And interestingly, Matthew mentioned Watford as a good example. And in my research, looking at all local plans in England 2 years ago to see how they built in health into their policies, Watford actually come up top in terms of how they built in health across all the policy areas, not just one policy area. Regardless, without going into great detail, if you see the colors there, the darker the color means the policies exist and their health links within those policies. The lighter the color, like towards yellow, bright yellow, means actually there is either no policy or there isn't any health references within those policy areas. So you can expect good references in air pollution, noise pollution, green spaces, active travel. But when you get on to issues like energy efficiency, urban heat island effect, and overheating, many of the health references and health focus aren't there in local plans, which is a concern because obviously health isn't a primary objective in those situations. But regardless, there's a lot more we can do when we do local plan reviews over the next few years to build in health into those policy areas. Next, please, Joe. Next slide, please. Thank you. So the other thing, looking at context, health does vary by geography. It depends on where you live. You can have the same housing, the same development in different areas, and the health outcomes could be very different, and the people living in them and experiencing them will be very, very different. And I use this infographic to show health inequalities as they apply and relevant to the town planning development sector. We all use the same land. We have the same land to plan with, to design and live off, and what you do with that piece of land, the same piece of land, is really quite important. So by achieving health net gain, you're essentially trying to ensure measurable kind of benefit for health for different population groups on the same piece of land, and you balance that against socioeconomic, environmental objectives. But that's the whole idea, is that for that same piece of land, you design with the people that will be living there in mind, or at least people who may be living there in the future in mind. As Andrew mentioned, we're aging population, but not everywhere is aging. The cities are younger, there are more families, and therefore you can't have the same design solution, planning solutions for every single place. They have to be designed with different places in mind. Next, please. Thank you, Joe. The final slide, please. Thank you. So all that can't be done, what we want to achieve in policy, design solutions, all that can't be done if you can't have the right people in place. And there was a select committee report earlier last year by the Health Select Committee into healthy places. They said that we need to build and have the right people and right structures in order to achieve healthy places. And evaluation has been very clear around some of these issues. There's been evaluation of posts, local authority officer posts in England that looked at some of these dedicated posts, and they have found that without the presence of these posts, the scale of activities around healthy placemaking would not have been achieved. And so therefore, I do agree that there'll be challenging financial situations for councils in the coming years, as Andrew mentioned, budget cuts and those key issues. Regardless, councils are making the value case for having these posts because they do, not just because they're nice to have, and because actually they are nice to have because there's no legal requirement to have these roles. By having these roles that straddle planning, regeneration, housing, and public health, they can make a tangible difference to healthy placemaking outcomes for the local communities. Slide button there. One more, please. Thank you. My final proposition and provocation to the audience and to the other speakers will be planning for health does not happen by default, and there's a good health and poor health. So having a strong health-oriented regulatory framework is necessary and maybe a prerequisite and ensure due process and achieve health outcomes for the future. Thank you.
Thank you so much, Michael. Yeah, really fascinating and really good to see how that builds on the points of the last two speakers. Our final speaker is Jane Klossick. Jane, if you could introduce yourself just while I bring up your slides.
Good morning, everybody. My name is Dr. Jane Klossick. My pronouns are they, them, and I am Reader in Architecture and Urban Design at London Metropolitan University. And I'm also Academic Supervisor for the Newham University Hospital Healthy Placemaking Knowledge Transfer Partnership, which is an Innovate funded project in which we've placed a wonderful knowledge transfer partnership associate into Newham University Hospital. And her name is Taylor Steele. I believe she's here today. And Taylor is a qualified architect and landscape urbanist who will be working for the next 2 years, within the structure of Newham University Hospital in order to create a vision for the hospital. Are my slides up?
It should be.
Great. Next slide then, please. So what do we mean by healthy placemaking principles in Newham University Hospital? So we're talking about promoting active travel across the site, which is I think it's about 13 hectares, the site just in Plaistow, to the north of the A13, which is the huge 4-lane motorway which goes east to west. We're talking about access to nature, collaboration and community engagement, sustainable materials and biodiversity, encouraging social interaction, reducing pollution, safety, sense of place, and accessibility. And it's important to note, of course, as the other speakers have discussed, that the design and quality of healthcare environments can really affect well-being. And in the case of Newham University Hospital, particularly the well-being of the staff and the patient experience and the overall healthcare outcomes. Next slide, please. So Newham Hospital is one of 4 hospitals in the Barts Health NHS Trust, and it's situated right in the heart of Newham, as I said, providing a range of core services to the people of Newham and to parts of Barking. And they provide high quality emergency care, and they see around 500 patients a day. But Tom Ellis, who's the head of strategy, describes them not as a sexy hospital. So they are a workhorse hospital for the locality. They have the largest maternity service in the group, with about 5,000 babies born every year, and an elective surgical centre providing orthopaedic surgery. And as you can see from that map, they are between the Greenway, which is the big green link to the east and west of Newham that runs along a sewage pipe, which leads to the sewage works in the east of Newham, and also between that and the A13. And they are quite disconnected in terms of transport. Next slide, please. And this is an aerial image of the hospital. And to say a little bit more about its surrounding context, it has the Beckton Park just to the south. However, it is completely disconnected from this park by the A13. There are two main entrances to the hospital, to the east and the west, and one entrance from the Greenway. So on this slide, the Greenway is on the left. The hospital is the blocky building in the centre. And the buses stop on that road that you can see just to the right of the hospital. So there are 2 or 3 bus stops there. The nearest tube stop is Plaistow, which is about a 25-minute walk. So it's very inaccessible, both really in public transport and on foot. But unlike a lot of the other hospital sites in London, Newham has a lot of space. It's got a lot of outdoor space. And although it's piecemeal at the moment due to the development of the hospital, it's very underutilised and under-programmed, this green space. Maintenance is tricky because there's a very limited budget, as we've discussed already. And a lot of the space is dominated by parking because of the disjointed public transport, meaning that staff and patients still frequently rely on driving. Next slide, please. 5 minutes really does go in less than 5 minutes. So the key project outputs are going to be this co-design process in which key stakeholders, so that's staff, patients, students, visitors, and local people, are going to inform the development of a spatial master plan or a vision for the site, which will embody healthy placemaking principles, which I outlined at the beginning, informed by the co-design process, but will also include short, medium, and long-term implementation strategies. So that's looking at how can capital project funding, which comes online, be strategically used towards healthy placemaking goals. And finally, this project really hopes to embed the spatial literacy and new planning capabilities that it develops into the decision-making processes and management structure at Newham University Hospital. Next slide, please. Newham is a very deprived borough. It's very ethnically mixed with a high turnover in population. And on the whole, the primary and community service provision in Newham is poor, which means that a lot of people come to hospital when actually it might be better for them to use other services. There are very high rates of diabetes, asthma, respiratory problems, and cardiovascular diseases. And one of the objectives of this project is that the hospital is no longer just a place where people go when they have ill health, but it's a place that the local community can come in order to improve their health and as part of a healthy lifestyle, so that this huge amount of space is used in the borough effectively. Next slide, please. Finally, our key project objectives. And this is in order to get the funding from Innovate, we have to demonstrate that we'll save money in the operation of the hospital. And one of the ways to do that will be improve staff wellbeing so that they don't leave as much as they do, and so that bank staff are not being paid for as much as they currently are. Support preventative healthcare, therefore saving money overall in treatment, and to transform Newham University Hospital into an asset for the local community, and also as an exemplar of a healthy hospital, testing these mechanisms so that they can be expanded out to the rest of the group in Barts Health Trust, and also beyond towards the rest of the NHS estates. So thank you very much. That's my presentation done.
Thank you. Those have been really great presentations, and I'll forgive the slight overrunning just because I think it's been so interesting to hear all the different points. I think what's been kind of particularly interesting to note has been this kind of range of scales between national policy, local policy, and actually site-specific interventions. I think I could open this up to all of the speakers, but how do you think we balance that difference between the need for a national drive and these kind of local interventions, and maybe the efficiencies between those different levels of planning and policy?
So I think if I'd like to come in there. I mean, first of all, I think planning policy plays essential enabling, safeguarding role, ensuring that the built environment delivers value, health value, whether it's physiological or mental health value, for people across all different social backgrounds. And we're inherently a more connected world than ever, where people are, where movement is key, and the weight on that has increased, the importance people place on their health and connectedness to people, and being able to have these places that are good for everybody has increased, I would say, since COVID. And there are really good examples in pockets within local policy, like the Watford example, or it's done in a lot of different ways across different authorities. If you look at health or, by extension, neurodiversity, for example, Hertfordshire has a service provision and placemaking guide, and that's the way they incorporate their dementia-friendly design principles through that guidance. Milton Keynes has a supplementary planning document about a similar sort of subject. So the ways of implementing it are inconsistent. The mandate is clearly there. And so more of an increased national focus and joined upness to communicate and talk about it, and have a base of what is good practice and what works across different places, people talking to each other and sharing that good practice, is more important now than ever. And we have such an abundance of information in the world that we live in to draw from. The importance of making that visually, digitally accessible, to share and increase efficiency of, this broader idea as to what is good practice, is more important than ever, but still allowing, things like neighbourhood plans, parish councils, authorities to supplement that with identifying the needs they have in their areas.
Yeah, really interesting. Andrew, can we bring you on that as well?
Yeah, I mean, first off, sorry for dropping off. It was an automatic update. You've got to love Windows, always the perfect time. Yeah, in terms of the policy side of it, I mean, we have national policy that is intended to protect and promote health. The problem is health is so complex and multidisciplinary, you can't have an overarching policy that will be good for everybody. So that's where local plans come into play. And we are seeing examples of excellence. You take the Cherwell local plan, Reg 19 at the moment. They have health promotion policies. And not only that, they actually direct developers on how to actually deliver local priorities and needs. And they have a requirement which sets out, don't wait until you've drawn out your urban design as part of your vision, as part of your pre-submission discussion. You have to have a heading called health promotion. And they've written it in a way that, and Matthew touched on this earlier in his presentation, on helping planning officers attribute positive weight for healthy urban design. Because at the moment, there's no distinction between a good project and a bad project in planning. Very little planning weight is given for a project that will improve things or not. And making that easy, simplifying it, is key to recognizing good exemplar projects. And what Michael said as well, we already have regional champions out there, some of whom are on the call today. We need to recognize and value what they do. And that is all driven from the hierarchical policy down. So.
No, such a good point. Thank you. Just a reminder that if any of the audience have got any questions, please get those into the Q&A, and we'll leave a few minutes for those at the end. In the meantime, I'll take my privilege as chair to ask another one. I think those points about planning policy have been really interesting, but how do we go into more detail about actually valuing these steps and really weighing them up against some of the other factors? Michael, have you got anything that you can add on that?
I can add to it. I don't have an answer for it. If I didn't know, I think wouldn't be in this webinar. But I mean, it's always going to be challenging, because what you're trying to do is you're trying to monetize and quantify people's lives and health against other, factors that may be more easily quantifiable. So it's always going to be a judgment in there somewhere. But I think, what you could do, it's something that we are trying to explore with James Stewart Evans and Dr. Chagla Coxall from Manchester, is to see how we can apply the concept of health net gain. How do you try and put health, at least in those consideration processes, to be on par with other economic considerations? Because at some point, we're going to have to try and say, well, how does health, go against, or it'll be aligned with housing delivery and all the other things that, that benefits healthy placemaking. One final thing to add is I think there are plenty of frameworks out there. Matthew did say there's a lot of information out there, and that is a positive, but also a challenge, because there's so much information that when you're trying to apply some of these principles, you just don't know which framework is the right one or is most appropriate for your local area. And then practitioners end up creating their own, adapting an existing framework. So we did a piece of research about 3 years ago looking at frameworks, and there are many of them out there, both nationally and internationally. I think the key thing to add is that there's no reason why you can't adapt a framework for your local circumstances. And the key thing is about engaging the right stakeholders in the process.
Thank you. I think that stakeholder point maybe brings me on to my next question, which was to Jane, kind of asking about actually how do we ensure that we do get the right stakeholders around the table and that this is a kind of representative and diverse group of stakeholders. What's the challenge on that on a more local level?
Well, I think to just start, I'd like to follow up from what Michael was saying about adapting frameworks locally, because certainly in relation to the Healthy Hospitals, Katie, the Knowledge Transfer Partnership, there isn't really a single agreed framework which can adequately quantify the value of all these health-led design decisions. And the evidence that we've gathered so far is really suggesting that design is very contextually driven and it's relationally produced what's valuable because of the diversity of stakeholders. So in any place, because this is why placemaking is such a valuable tool and concept, it's a complex system, and you can't really easily think about it in a technocratic way. So I think a universal framework will flatten the nuances that are specific to place, and rather I think the important embedded principle of healthy placemaking should be that it's developed through engagement with the nuances and complex systems that you encounter in any particular place. So the value is, and I think partly also possibly the healthy placemaking outcomes for us in our project are not just in the design outcomes, but also in the process itself. So the co-design process. And one of the aspects of this project is mapping the stakeholders. But what I guess concerns me in observing, and I'm quite new to this world of healthy placemaking, although I've been looking at cities and looking at what makes humans flourish for a long time. I haven't ever before given it the title healthy placemaking. But one of the things I've observed is that it's not a very diverse group of people being the healthy placemakers. There isn't a lot of, I guess, ethnic diversity and gender diversity and so forth in the people I've encountered so far. And it would be great if we could find mechanisms to improve that. I don't at all have an answer to that. But that's, again, I'm like Michael, that's one of the reasons I'm here.
No, fascinating. I've had a couple of questions come up in the Q&A, so I'll give a minute to those. I guess we've spoken a lot about this kind of top-down, bottom-up approach, but we've got an anonymous question asking what local communities can do from the ground up in the absence of top-down action. Jane, I think you've touched on some of those things, but are there any other examples that any of the panelists can come up with for that? Jane.
It's such an interesting question. And I think, again, it's so place specific. But a project that comes to mind is the Livesey Exchange, which is in the Old Kent Road. And that is an occupation of a piece of its land earmarked for redevelopment, but it was a meanwhile use, which an architect called Ulrika Stephen, over a long period, like a decade, started doing temporary occupation along with a group called PEM People of different pieces of space in the borough. And over time, this has become a permanent occupation of this piece of land. So I think it's very much place specific and very much about finding bits of land. This is from an architect's perspective and an urban designer's perspective, bits of land where things can happen, because it's only when things are actually happening in a place where people come together that you get that magic of imaginative ideas and the ability for people from different parts of a power hierarchy to communicate with each other.
Thank you. And Andrew, have you got anything to,
Yeah,
any other points to add to that?
I think it touches on the fact that when we say value in placemaking, value to who? Who ultimately values from this? And there's different stakeholders. I've talked about local authority, healthcare, preventing, reducing, delaying demand. But then there's the individual, the communities. And the more insight, the more intel, the more understanding, the more empathy we have that we can actually build in. As I said, behavior, you can build something, but unless you actually address some of the barriers to using it, unless you actually put yourself into their position and understand what works or doesn't work for them, then it could be for nothing. So what's the value then? So engagement is critical, and we're seeing that not just during local plans, which are essential, because that local plan engagement, that input there, will filter down to developments. It helps set priorities and needs. But on individual projects too, the main point that we get to on consultation on projects is often, I don't want it, and it stops there. Provide more. Say what you need in the area. Say what is requires attention or doesn't work. Just anything you can share that can be turned into a healthy urban design solution to resolve that, the better. We're also seeing more in the way of rate my space type information being collected now, where the digital age, the way that information can be gathered through QR codes or whatnot, is being applied to not only buildings, offices, but places and spaces between them. So we are seeing more input, but how it's applied and where it goes to is the tricky part.
Thank you. Matthew.
Thank you. Yeah, I alluded to this a few minutes ago about the importance of neighbourhood planning and what parish councils can do and the way that people can filter into that process. And while there's a shift towards a regionally focused planning in particular at the moment, I think that neighbourhood plans in particular can play a really important function in distilling those needs and doing that ground up sort of action. So for the last 2.5 years, I've been sort of in a more hybrid, nuanced role between town planning and social value. And as a social value practitioner, it's really refreshing to see when you have a neighbourhood plan that has something of a menu, as it were, at the end of these are all the infrastructure improvements we want at a very local level within our area, be it improvements to a byway, improved sign posting at a certain place, refurbishing the town hall, whatever it might be. And so I think when that's properly engaged with, especially with a diverse range of groups, being engaged with that process, I think there's a lot of value that neighbourhood plans can extract of what is the local need here, what sort of infrastructure improvements can be. Do we want our community infrastructure levy or Section 106 plan legal obligations to go towards? Be it, for example, using the byway example, do we want a developer to come along and, as an added social value benefit, resurface this byway so that it's accessible to people with disabilities a lot more and they can access nature? Do we want, wayfinding improvements so that people with certain forms of neurodivergence don't feel so daunted to get out and about and interact and get some fresh air? There's a lot of things that we can do, and that way that would give developers sort of straight away, okay, I know what the local community wants. I'm going to do that rather than tell you what I think that you need.
Really great point. Thank you. I've got one last question I think I might have time to get to, which would be great to cover quickly. Michael, you might be able to offer some help on this. I know we spoke about frameworks, but this question specifically about health impact assessments. I wonder if you've got any final kind of comments on the roles that those can play in planning and design.
Yeah, I mean, like frameworks, there are plenty of assessment tools out there, and health impact assessment is one of those. It's probably the only public health specific lever in the planning system. So it can actually play a very, very useful role. How you go about resourcing that and implementing it is a different question. But I will say is that local authorities are really looking at HIAs as a key mechanism for delivering healthy placemaking. So it's not going to go away. So, we can try and make it work and improve its implementation. I know Andrew's got a lot of experience in this area. What we're doing in the new year is trying to provide training. So if you do need further training, please, have a look at details out there. But HI is very useful, and it should become a very, embedded part of the planning system.
Perfect, thank you. And we've got 2 minutes left, so I'm just going to wrap it up. And I think we've had some really interesting points, an amazing crossover between all of our speakers. But I know that there's lots of knowledge sitting in the audience as well. And as part of what we'd like to do as a wrap up of this event is we're going to kind of write up some of the insights that we've found. So it'd be really interesting to hear some of your insights. So if you can comment on our LinkedIn post or send us a message on LinkedIn about your thoughts about what your challenges are, about any great examples that you've been involved in, any case studies you can share, that would be really, really valuable for us to start to collect. And I'd like to make a final kind of thank you as well to our sponsors, Savills, who have been really helpful in putting together and making all of this webinar work today. With all the technical difficulties that can happen. So yeah, I'd just like to say a huge thank you to Savills and to all of our panelists today for joining. And thank you to you, and I hope you have a good rest of your day and can get that coffee in now.
Thank you very much.
Thank you.
Bye
Thank you.
all.